Hello, Dr. Edward Juni here, and today we're going to continue our discussion on complex cases and buprenorphine treatment. This is our fifth lecture in the series and our second presentation that's exclusively focusing on complex cases. As I said during the last presentation, I feel that cases are probably one of the best places to learn because it introduces real life problems, and these are real cases, and it can certainly help clinicians develop a better understanding of opioid use disorders and their treatments, especially in complex situations. Okay, so there are no disclosures. As we do with each presentation, we're going to start off with the action period assignments from the last lecture. And the first one here is that do you currently counsel your opioid use disorder patients on medication assisted treatment on alcohol use prior to prescribing buprenorphine? And if so, what do you advise your patients? If you recall, during the last lecture, we had presented a fairly complex case of a patient that was struggling with opiate addiction and was on buprenorphine, and we found out that she had a co-occurring alcohol use disorder in addition to misusing other classes of pills. So I would be very interested to hear what type of response that you guys would provide to this question. I'll tell you what I do. We basically advise, at least I advise all my patients to completely abstain. And as I discussed at the end of the last lecture, this is predominantly to help us monitor the patient, because if you basically give an approval for casual alcohol utilization, number one, you're never going to be able to appropriately monitor the patient for excess alcohol use. And secondly, you never really know how much alcohol that they're drinking. The third reason is one of potential harm. Buprenorphine has been known to cause liver toxicity in some patients. And given the liver toxicity associated with heavy drinking, it is just not a good combo. The other thing in general, remember, buprenorphine is a Schedule III opioid analgesic. And just as a class rule, it's not a good idea to mix opioids with alcohol, period. So I would advise anyone that's listening to this presentation to advise complete abstinence from alcohol. If a patient on buprenorphine with no history of alcohol use disorder, psychiatric illness, or other substance use diagnoses asked you if he can have, quote, a drink of wine with dinner a couple of times a month, what do you advise the patient and why? And again, the answer here is no. One, again, as we just discussed, because you can never actually determine how much alcohol somebody is drinking, and it's very difficult for you to monitor that patient. So it's best to advise complete abstinence. Now, granted, there's probably differences of opinions on this, but I feel that this is the best course of action, especially those that are struggling with more on the severe end of an opioid use disorder. The third one, you inform a patient that his urine tested positive for ETG and ETS, and he responds to you, quote, "I don't consent to that. I don't drink. I'm not paying for the test. That it's completely unnecessary." What is your reply to the patient? So this is an interesting scenario, and this can certainly happen in the real life clinical world. And the response is that you have to explain to the patient is that we need to monitor everybody, and we need to monitor everybody in a similar fashion. And you certainly understand that they don't drink, but that doesn't, just the history in itself does not exclude them from the panel of testing that has to be done. Because again, you have a responsibility to monitor them. You have a responsibility to yourself as well as to your state medical board to ensure that you're executing appropriate healthcare. And this is what I share with my patients. I say I have a responsibility to take care of you, and I have a responsibility to do that in an ethical and an appropriate and in a manner in which that is consistent with the current guidelines. And I certainly understand you're not drinking. I understand this may be cost burdensome for you, but This is the way we need to monitor the patients taking this medicine, and I need to do my job in taking care of you. So that would be a good response, or any variation thereof. And again, I'll provide my email address at the end of this presentation. If any of you have alternative viewpoints, or if you'd like to share your thoughts, please don't hesitate to drop me an email. I'll be happy to hear what you have to say. So today, the real objective is that we're going to learn from these cases. So again, as with the cases in the last presentation, these are all real. So these were not made up. These were cases that we actually encountered in a clinical setting. There are unexpected outcomes here. These are used as a training tool. A lot of the treatment interventions that we have implemented here were not based on evidence-based medicine. They were based on clinical intuition. Meaning that we had to make a decision at the spur of the moment, and really going through the medical literature and consulting with colleagues was not an option. And for those of you that have been doing medicine for a long time, you know that that's the way that you have to practice sometimes. So I'm putting that out there just as a disclaimer, is that what we're going to be implementing here, we're living in the gray area, and we're doing, at least at the time, what we thought was best for the patient. And again, we are using this as a learning tool to help you manage similar cases in the future. Not everything we did here was right, and I'm going to set that out there up front. You're not going to learn from people presenting you cases that are wrapped up and placed in a bow and they're all nice and tidy. You're going to learn from cases where, looking back at it, we could have done things differently. So we're going to start off today talking about Cindy. Okay, so let's dive right in. So Cindy is a 33, at least at the time of the presentation, she was a 33-year-old pregnant female. She was at 12 weeks. And she presented to a collaborative care clinic at University of Michigan, which is a clinic that offers both obstetrical as well as addiction medicine services. And she had a history of heroin addiction and really severe anxiety. She had reported heroin use for approximately 2.5 years, but she stated that she had been completely absent from the drug for approximately 7 years, at least 7 years prior to presentation. She was briefly in a methadone maintenance clinic for approximately 9 months, and she was on buprenorphine for 3 years, but she stopped this about a year ago. Currently, at the time of the visit, she was not on any medication-assisted treatment, meaning she was not on buprenorphine, methadone, and she was not on naltrexone. Interestingly, within the pregnant population, at least as far as I know, there isn't any validated study that's looked at the utilization of naltrexone in this population, and that's for a variety of reasons. Anyway, and the other thing is that she was not requesting Suboxone. She was not requesting any kind of MAT. She just came to the clinic. She said, "This is my history. I have severe anxiety, and I would like the services that you guys have to offer." So she really wasn't making any kind of a request. She did state, again, this is the first visit. So as I said before, that she was prescribed buprenorphine about a year ago, and she said she still takes some occasionally from an old prescription. And was using about 1/4 of an 8-milligram film every few days. And she felt that she can stop it at any time. Normally, when you have somebody that's stating they're using a controlled substance from a quote unquote an old prescription, that's usually never the case. Normally what they're doing is that they're purchasing it illicitly, and they just don't want to disclose that. It's just much more comfortable for them to tell you that they're using it from an old prescription, because this way you're not going to give them any kind of a lecture, and you're not going to document in the medical record, especially somebody who's pregnant, that they're purchasing drugs off of the street. So patients are generally very careful of what they tell you. So although she said it was from an old prescription, we kind of knew that she was probably purchasing this from other people. So what was she taking? So she was on Xanax. She was on 1 milligram twice a day. She was on Zoloft, gabapentin, and Seroquel. So what was her psychiatric history? She had a history of major depressive disorder, OCD, and generalized anxiety disorder. And she stated that anxiety was her primary concern. On the, I don't have it down here, but just with respect to the mental status exam, is she appeared anxious. She appeared to be a nervous lady, which at the time we didn't think was that unusual, because when we have pregnant moms presenting to this clinic, especially for the first prenatal visit, they are anxious. I mean, they're pregnant, they're discussing drug use with us. So it can be a little bit unnerving. And so we weren't really that surprised by her demeanor and what we found on the mental status exam at that time. So she had a history of 2 psychiatric hospital stays about 3 years ago, one of which was following a suicide attempt. And she was contemplating jumping off a bridge, but somebody had intervened and they had stopped her. The hospitals in the suicide attempt were triggered by a newborn baby being taken away due to her substance use difficulties. And as she progressed through the pregnancy, this continued to be a profound source of anxiety. So even though that she was being compliant with treatment, and we'll talk about how she was doing, I guess, reasonably well. But this was a core issue with her. She was terrified that she was going to encounter that at the time of the delivery, that something similar was going to happen. She wasn't under the care of a psychiatrist, and she was not currently engaged in any form of psychotherapy. So this piece of history here is actually important from a mental health perspective. Obviously, a suicide history is anytime going to, I'm sorry, a suicide attempt at any time is going to be pertinent. But this was in the context of one of her babies being removed from her home by Child Protective Services due to substance-related concerns. And now she's come to us, she's pregnant, she has a history of drug addiction. So we need to watch her and we need to monitor her very closely. And this also illustrates the importance of history gathering. When you're doing your first assessment, the questions you ask are imperative. So one of the things you want to do, especially in a mental health patient, is you want to ask if there's any previous history of psychiatric hospitalizations, suicide attempts, and you need to ask the context of the suicide attempt. And very simply, you do it in an open-ended way that is non-judgmental. And a good thing to ask is just very simply, so what was going on at that time? So if a patient says in 2003, I had taken an overdose of Ambien, your response to them, tell me what was happening at that time. Okay. Were there any triggers? Walk me through what happened. I think it's important for me to know so I can better treat you. Another thing to do, and I believe that I've articulated this in prior presentations, is when you're dealing with, and again, this may be a very sensitive issue for some patients, and if you notice that they're somewhat apprehensive or they're appearing anxious during the course of the assessment, ask permission. So it would go something like this: do you have any history of trying to hurt yourself? The patient may say yes. And then your response is, I'm sorry, let me get rid of this. Would you feel comfortable sharing that with me? Right? So you're asking permission. So that's a good clinical move. It places the patient more at ease. And in most cases, they will provide a history, but it's good for your rapport to ask permission when we're dealing with sensitive content like that. So going to the questions on the bottom of the slide here, again, this is not a live course, but during the live course, we would have a group discussion about what would be done at this point, and we would ask the audience participants what other information they would like to have. So if you want to take time to do that and make a mental note of what other information that you would want, pause the presentation and then we'll continue. So going over Cindy's substance use history. So as we talked about earlier, she used heroin for 2.5 years before participating in a long-term residential treatment program. And during that time, she was placed on methadone, and she was on methadone for approximately 9 months. And she did well on it, meaning that she did not utilize any opiates when she was on methadone maintenance treatment. And that's something you want to do when you're asking patients. First thing you want to ask is what type of treatment they've had for their opiate addiction. And you need to ask explicitly if they've ever been on, the 3 approved medicines, buprenorphine, naltrexone, or methadone. And when you're going over those 3, and if they've had previous trials, you want to ask them, what was your experience with that drug? Okay, you want to know, did they use, did they not use, was it good? Did they stop because it was too expensive? You want to know what their clinical course was, and if they stopped it, why did they stop? So for her, as with most of our methadone patients, she just didn't want to go to the methadone clinic anymore, and she just did not like being on it. So after she stopped methadone, she was placed on buprenorphine, which she was on for 3 years before she stopped the medicine approximately a year prior to her presentation. And she just stopped it just because she didn't want to be on it anymore, and she didn't want to continue to go to the clinic and obtain prescription refills. She was on Xanax, as we talked about, and she did admit to us that there are times when she takes more than the prescribed amount. We didn't feel that this was indicative of any kind of a benzodiazepine addiction. She was just taking more just to help her cope. So although she had reported on occasion taking more than the prescribed quantity, we didn't feel that this wasn't anything that was that clinically concerning to us. There was no other history of any other substance-related difficulties, and she was attending meetings approximately 2 to 3 times per week. And again, it's important to gather this history from patients. You want to know what they're doing within their own recovery community, ask if they're attending meetings, and how are they responding to those meetings? Do you like them? Do you not like them? I usually ask my patients, are you going to meetings? If they say yes, I say, how is that helpful to you? Is it helpful to you? Do you enjoy going to the meetings, or what do you get out of the meetings? If they don't enjoy it, if they don't like going, I ask, well, then why are you still going? But I think it's helpful to know what they find positive and what they find negative about their own recovery experience. Her social history: she lives with mom, she lives with her mother, she's never been married. As we talked about, she gave birth 3 years ago, but the baby was taken away by CPS, and this was extremely emotionally traumatic. She's not currently employed, but was trained as a medical assistant, and she was on, at least at the time of this evaluation, she was on probation for disorderly conduct and jostling. No other history of psychological trauma. Her father had a significant history of an alcohol use disorder, but was in recovery, and she identified him as being a very supportive figure in her life. So the second visit, which is the first follow-up visit for her, we got a drug screen, and showed basically what she was prescribed. It showed alprazolam, gabapentin, sertraline, and quetiapine. The MAPS report showed regular prescriptions for Xanax, but there was no concerning activity. There were no early refills. She wasn't utilizing multiple providers, so everything looked reasonably well during the first follow-up. And so, what would you recommend for this patient? Right? What about this case thus far is most concerning to you, and what other information would you like to know? Now, we're going to obviously discuss this in future slides, but just a couple points. The first one is that I want you to consider is that because she's doing well, it doesn't necessarily mean you don't do anything. Because of course, she's reporting, some baseline anxiety that really hasn't changed that much. But you want to look at the whole picture, and you want to make some determinations with respect to what's going to be the best course of action for this patient. And you'll kind of get what I mean here in the slides to come. We did recommend the detoxification of Xanax. And the reason for that is that Xanax is a very reinforcing drug. She did report that she was misusing it, as we talked about, and because of her other substance use history. So I have somebody that's pregnant. She has a history of heroin addiction. She has a history of 1 suicide attempt. She reports that she misusing it, although we didn't feel that she had a benzodiazepine addiction. But you have to ask yourself, why am I endorsing the use of this medicine? And obviously, if you're going to take over prescribing, even more so, why am I prescribing it to this patient. Now, we're at a fork in the road here. Now, I'm not saying that this is the thing you need to do. We need to put things in perspective, and everything is 20/20 hindsight, as we'll discuss as we get deeper into this case. But another fork in the road here is to keep her on Xanax. She's reporting tremendous anxiety. And for those of you that don't know, I'm sure all of you probably know by now, the weaning off of benzodiazepines is excruciating. It is very difficult. Do we really want to put her through that while she's pregnant and while she's going through this? So a lot of things to consider. We recommended the utilization of Klonopin because of its long-acting nature. So we elected not to just discontinue, not to taper the Xanax, but to do a substitute and essentially substitute the Xanax with clonazepam because it's easier to taper. So this is what we recommended to her. She still had a 1-month supply of Xanax, so we didn't do anything. We just basically said, this is what we're thinking about. You know, when you come in for your next visit, you'll be closer to ending your Xanax prescription. We can talk about it more at that time. We obviously encouraged her continued participation in meetings, and we recommended outpatient treatment services for her substance use with somebody in the local community. So we gave her, so basically what we're saying is that we want her to engage in at least some form of support. We didn't felt she needed an IOP or a higher level of care at this point, but the bare minimum, she would need to be plugged in with some basic outpatient services in addition to what we were doing. And that would be either meeting with a counselor regularly or getting involved in some type of a professionally facilitated recovery group. And we were, of course, going to follow her with regular urine drug screens and prescription monitoring reports. And we wanted to see her again in 2 weeks. So taking this information into consideration, please take a moment and contemplate if you would do anything different. So at her third visit, which is the second follow-up visit, she reported continued intermittent use of non-prescribed buprenorphine, again, which she said was from an old prescription. Now she reports using Xanax. She's saying it again now. She's using more than prescribed, and she's using it on days when she's feeling more stressful. So before we get into the rest of the bullet points here, let's pay attention to the first thing we have here. She's continuing to report intermittent use of non-prescribed buprenorphine. Okay, so I want you to think about that and think about how it is that you would manage it. So we considered prescribing to her, but concerns arose because she was currently using Xanax, as well as, again, what we had determined was illicitly acquired buprenorphine. Now, I'm going to throw in a timestamp here because you need to understand the time frame when this patient was seen. This patient came to our clinic several years ago. I'm going to say it was maybe 2012 or 2013. It was basically early in my training. And back then, you know, when I was first starting to utilize buprenorphine, really there was a lot of talk around the campfire about not using buprenorphine in patients that were currently prescribed benzos. It was really considered to be a no-no, and especially the mentor that I was working with at the time was not a fan of it. So you need to understand the landscape. Now the pendulum has shifted, and we're certainly more tolerant of that, especially if the benzo is being utilized in a compliant and medically appropriate way. But back then, we were very nervous about it. So when we're considering prescribing buprenorphine, and we gave this considerable consideration at the time, we decided not to. And we decided to maintain her in an abstinence-based, meaning not utilizing any medication-assisted treatment, but with close monitoring and to encourage her to engage in community support activities and to plug into local groups or work with somebody individually. At the third follow-up visit, she reported that she was buying Suboxone and Ativan off the street. So now things are starting to escalate a little bit. And she reports that she was using the buprenorphine and the benzodiazepines, not because she was having cravings for opioids, but because her anxiety was escalating with regard to the pregnancy. We did a UDS and MAPS report. Those were unremarkable. We, again, discussed prescribing buprenorphine. But again, we were concerned about now she's purchasing lorazepam off the street and she's still acquiring illicitly obtained buprenorphine. So we felt that this would not be in her best interest. We recommended inpatient treatment. And actually on the last slide, that was a typo. We didn't recommend inpatient treatment the second follow-up. We only recommended it at the third one. So at this point, given the utilization of lorazepam and the continued illicit utilization of buprenorphine, we felt that she would be best monitored and treated in a medically supervised inpatient setting. And we were quite aggressive with this, but unfortunately she declined. And if patient declines, we can have a whole lecture on that, but there's really not much you can do. We certainly were not going to discharge her. We wanted to continue to monitor her closely, to see how she does, and to see her in 2 weeks and to reevaluate the treatment plan and to see what it is that we need to do for her. Visit number 5. We asked her, she came in, we said, did you consider the options for inpatient? She said, yes, I'm not going. She was quite adamant. She reported that she stopped using non-prescribed buprenorphine and had been off the drug for approximately 5 days. She says that she was experiencing opioid withdrawal and, quote, was feeling terrible. She was continuing to use Xanax and stated that she had been using 3 to 4 milligrams daily over the last 2 weeks. So her utilization of Xanax has escalated, but her utilization of buprenorphine has stopped. She said that she was going to run out of her Xanax prescription early, and she stated that her provider would not issue another prescription. She's asking for assistance with benzodiazepine withdrawal. So things are ticking up here a little bit. She's starting to not do well. So this is what we have here at the end of this slide. This is a fairly, what I would consider to be a complex clinical scenario. You have a pregnant patient that has a history of an opioid use disorder, has been utilizing illicitly acquired buprenorphine and benzodiazepines. She's on Xanax. She's overutilizing her prescription. She's about to go through a benzodiazepine withdrawal, and she's telling you that her provider is not going to provide a prescription, and she has declined inpatient treatment. A lot of things going on. And I think that you would agree that when you're in the office trying to manage this and you have to make a decision in 15 minutes, it can be somewhat challenging. So what did we decide to do? And by the way, let me, you guys probably already know this, but I'll tell you what I do. So when I'm confronted with something like this, and I have all these things to do, I don't make these decisions when I'm in the room with the patient. I basically leave. And I either go sit down somewhere or I meet with my colleagues and I take my time to think about what I'm going to do. It's very difficult to make treatment decisions when you're sitting there face to face with somebody, especially somebody who wants something, they want to be placed on a benzodiazepine to help mitigate their withdrawal. So it's good to kind of leave the room, go someplace where you can think and kind of write things on paper, think about how you're going to manage this. So that's basically what we did. And what we elected to do is that we elected to place her on clonazepam to help her wean off of benzodiazepines. And as I talked about, placing somebody on long-acting benzodiazepines such as clonazepam, diazepam, or Librium can help facilitate withdrawal because it's longer acting. We put her on 1 milligram twice a day, and we plan to decrease by 10 to 20% every 2 to 4 weeks. And again, we reiterated that she would be best served in an inpatient setting where they could monitor her benzodiazepine withdrawal, and she again declined. She reported that she got hooked up with a counselor within her county, and she was seeing this person every 1 to 2 weeks. She was happy with the relationship, and she was also encouraged to continue her participation in NA and AA, which she was going to about 2 to 3 times per week. Visit number 6, she's now at 21 weeks. It's been, she's now at 21 weeks, and it's been 2 months since her last visit. Since her first visit. She was tolerating the clonazepam at 2 milligrams a day relatively well. And she's back to using non-prescribed buprenorphine and reported to us that she was using a sliver of an 8 milligram tablet. And her last use of the drug was 4 days ago, and she reports mild to moderate opioid withdrawal. Her urine drug screen showed buprenorphine, but nothing else. So what do we do now? Right? So think about this. So she's still continuing to report the utilization of non-prescribed buprenorphine. Well, what we felt was that now this had been going on for 2 months, and this was not stopping. And we kind of felt at this point that this is not going to stop. And we could either do one of two things. We can either prescribe her buprenorphine and monitor her closely in the context of benzodiazepines. But again, back then we were a little bit hesitant to do that. What we decided to do was we decided to recommend a methadone maintenance program. And those of us that were involved in this case felt that that would be, without a question, the best treatment intervention for the patient. And we had presented this to her, and she adamantly denied. I mean, it wasn't just, thank you, doctor, I appreciate that, let me think about it for a few minutes. No. She started to say no even before we finished the sentence. So it was very clear that she was not going to participate in this, nor was she going to give it any kind of consideration. And if you want to think about it, why was methadone recommended? Do you agree with what we had, do you agree with what we had suggested to the patient? Why not prescribe buprenorphine? So let's look at this again. So we have a patient again. I'm going to set the stage for you. She's pregnant. She's using illicitly acquired buprenorphine. Why not just provide it to her? She's buying this. It would likely be easier for us to provide it. We can monitor her. She's likely experiencing cravings. She's not consenting to inpatient treatment. It may be a good idea for us to just prescribe this to her. So what we were thinking at the time was that she was misusing benzodiazepines. She was obtaining benzodiazepines from the street. We were also concerned that providing her with a buprenorphine prescription may escalate her use of benzos and other drugs, because if somebody is engaged in illicit drug acquisition, when you give them a controlled substance, you're basically giving them cash. So we were also worried that this would provide her a means to purchase more drugs, and we were very concerned with that. So methadone maintenance, with or without inpatient treatment, were deemed the best treatment option for her. There's an inpatient program on the east side of Michigan that's known as Sacred Heart, and they have and they do have a program that works with pregnant women where they place them on methadone maintenance treatment. And this is what we were suggesting to Cindy. But again, she was absolutely against it. Visit number 7, she's now at 24 weeks of gestation. We have her on Klonopin 2 milligrams daily. We had brought up to her, baby, it's time to start decreasing the dose a little bit. We'll just drop your dose by no more than 10%. She was not interested in that. And we felt fine with that. We didn't want to rush it. She was not doing well. We said, fine, she was using the Klonopin appropriately. She reports she last used buprenorphine 2 weeks ago. She was reporting withdrawal and generally reported that she was not feeling well because she had stopped Suboxone. By the way, and this is a good point to interject here, for those of you that don't know, I'm sure most of you on the call do, but tapering off of buprenorphine is extremely uncomfortable. It is a very difficult opioid to wean off of, partly because of its long-acting nature and because of its high potency. You need to discuss this with patients. I think this is important to disclose while you're initiating somebody on opioid maintenance treatment. Unfortunately, there are some clinicians who kind of sell this as, the silver bullet, this medicine's great, you're going to feel so wonderful on it, and there's no downsides, everything is up and up. That's not true. So I think it's important to have a discussion with these patients and let them know is that they will physically acclimate to this drug. It is an opioid, and because of the physical acclimation, if the medication for any reason is discontinued or if we need to taper it, you're going to get uncomfortable. You're going to go through opioid withdrawal. So I think we need to be transparent, and we need to discuss these things with the patients and their families. So really nothing else to report. Her urine drug screen was unremarkable. Well, kind of unremarkable. I mean, it did show buprenorphine, but she said she hadn't used in the last 2 weeks. which likely that was not an accurate report. She probably used it in the last few days. And again, she denied this despite what we saw in the urine toxicology report. So I'm not going to go over every single visit with you. We're just going to go ahead and summarize. So what happened in the subsequent visits. So she was compliant with off follow-up visits and end of the year and drug screens. This is somebody who never missed an appointment. She was always there. She was always on time. The decision was made to maintain her on Klonopin without a taper just because she was so anxious. And we just felt that, she's taking it appropriately. We're monitoring her. She's coming to all the appointments. She's being compliant. Let's just not rock the boat. Let's just go ahead and keep her on this, which is what we had elected to do. She continued to test positive for buprenorphine, but she only admitted intermittent use. We felt that she was likely being disingenuous and was using more than what she was willing to admit. Other than showing buprenorphine, her urine drug screens were fine. They didn't show any use of anything else. Now, again, I keep on going back to the anxiety. It continued to escalate. Even though we had her on Klonopin, which is a pretty potent benzo, we had also considered other. I didn't put this in the slide set, but during the earlier part of her treatment, we had considered, upping her SSRI dose and doing other things, but for various reasons, that wasn't thought to be the best thing for her. Okay. Okay. So moving along, how does this case end? So she was scheduled for an induction of labor and described anxiety to the nurse practitioner who was working in her clinic at the time. She said it was through the roof. So I keep on coming back to this anxiety issue, and we're going to talk about that as we go through the summary of this case. At 39 weeks and 3 days after her last appointment, she was found on her bed, unresponsive, with a syringe by her side. She was taken to a local hospital where her and her unborn baby were pronounced dead. The cause of death was a heroin overdose. She was 33 years old. We all went to the funeral. That includes myself, the nurse practitioner, the nurses in the clinic, the social workers, the medical assistants, even front desk staff. That's right. Even some of the people that work at our front desk who were responsible for checking her in and checking her out, they went. Because you need to understand, when we're monitoring somebody during pregnancy at frequent intervals, you see them almost every week, and you become close to them. You develop a relationship. So we're going to talk a few minutes about this. The first thing I will say to you is we did not see this coming. Now, working in addiction for 10 years, I can tell you is that, speaking candidly, there are cases that do have death as an outcome that I'm not surprised with. That you see it coming, they have a deteriorating course, they're not doing well, they're not engaging in treatment. We're doing everything we can, but it's just not working. And then, we get a notification that the illness had taken this person's life, and certainly we're saddened. But at the same time, we kind of thought that this would likely be the outcome. This was not the case with this patient, and which made it even more. It made it just so devastating to us when this had happened, because her urine, she was never using. I mean, she was using buprenorphine, of course, but with respect to relapsing and using her drug of choice, that was not present at all. So let's have a retrospective on this. Let's talk about it. We have a patient fatality here in the context of opiate addiction. The fact that she was 39 weeks pregnant made it just so difficult to deal with. And I've spent many years thinking about this case, thinking about what we could have done differently. And there were things we could have done differently, and I'm going to go over those with you so you guys can learn from this. So, was this a suicide? I don't know, and we will never know. Could it have been? I think it's a possibility, but I don't know. And I kept on talking about the anxiety, and that was a huge part of this, and it was escalating. Now, of course, we all manage anxiety in the clinic. I mean, we see this every day, and of course, everything is 20/20 hindsight. But could we have paid more close attention to this? And instead of focusing on her use of buprenorphine, should we have focused more on the anxiety? And that's something that I think about. As I talked about, we did not expect this. Her urine drug screen were never positive for heroin or any other opioid. She was very compliant. She was always, never missed an appointment, always on time, never argued about providing a UDS. She was a very compliant patient. What were the warning signs here? She had a history of IV heroin use. She had a history of 2 inpatient psychiatric hospitalizations that occurred that were associated with her last pregnancy. So because during her last pregnancy, her child was taken away, this was emotionally traumatic to her and resulted in 2 inpatient psychiatric hospital stays. She had an aborted suicide attempt following the last delivery. And as I talked about many times before, is that her anxiety was escalating. Her anxiety escalated dramatically when she was advised that she was going to be scheduled for an induction of labor. So my thoughts, what we could have done differently. Now that I look at this and I'm sitting here looking at this 7 to 8 years later, she should have been placed on buprenorphine. And we should have been very liberal with our dosing escalations to ensure that she was comfortable. This is the one thing that I would have done. The issue with the benzodiazepines kind of sidetracked us and we elected not to do it. But now that I'm able to reevaluate this case, given the years of experience that I've accumulated since that time, this patient should have been placed on Suboxone quite early on in her pregnancy. And again, she was taking, at least what she was telling us, she was taking just slivers of a tablet because she probably wanted to make it last. So she was likely not utilizing what she needed to utilize. And how much of this was a contributor to the outcome, who knows? But that's one thing to consider. The other thing to consider is to keep her on Xanax. Again, going back to the anxiety piece, she was not doing well. It is now a time that we really want to start fussing around and switching benzos. Probably not. Given she had a history of misuse, what I likely would have done was limit her, give her 1 to 2 week prescriptions, and just monitor her closely. Okay, so just to summarize, what I would have done in this case, I would have placed her on buprenorphine early on in the pregnancy, with being quite liberal with dosing, maintaining her on 16 to 24 milligrams, whatever makes her the most comfortable, keeping her on Xanax at the prescribed dosage, with appropriate monitoring to ensure that she is not overusing it. Would have this made a difference? I don't know, and we will never know. What do you guys think? So take a moment, make a mental note of what you think that you would have done differently. And if you want to share that with me in an email, I'll certainly be happy to hear your thoughts. Okay, so that was Cindy. That was a sad outcome, but unfortunately, when you work in this business for a long time, those are going to happen. And this just emphasizes and and helps us remind ourselves that this is a deadly illness, and occasionally patients succumb to this illness. Okay, let's talk about Becky. So Becky is a 33-year-old pregnant woman. We have another pregnancy case here. She's at 29 weeks, and she presented with a 6-year history of heroin and methamphetamine use. She was recently treated in a long-term care facility and was placed on Subutex, 8 milligrams 3 times daily. She was discharged from residential treatment 10 days prior to presentation. She reports that only days after discharge, she began using heroin and methamphetamine again, in addition to prescribed buprenorphine. We got a urine drug screen on her. It showed morphine, methamphetamine, marijuana, and buprenorphine. Going back to our urine drug screen lecture, which was 2 or 3 presentations ago, let's talk about morphine. What does morphine show? What does morphine mean? Morphine means usually one of 2 things. Well, actually one of 3 things. 1, they're using morphine. They're using either MSIR or they're using MS-Contin, but they're using some morphine formulation. The second thing it can mean is they're using codeine, which is in Tylenol 3 or Tylenol 4, just any codeine-containing product. Why? Because you remember, codeine is metabolized to what? Codeine is metabolized to morphine. And what's the third thing that the morphine can be coming from? It could be coming from heroin, because heroin is metabolized. Heroin is diacetylmorphine, and heroin gets metabolized to 6-monoacetylmorphine, or 6-MEM, and that gets broken down to what? That gets broken down to morphine. So you have 3 sources of morphine, and when you're reviewing a drug screen, you should know that, because it can help you determine what the patient is using. Her psychiatric history: she reports a history of manic depression, multiple inpatient psychiatric hospitalizations due to drug overdoses, and she reports that the overdoses were due to addiction and were not genuine suicide attempts. She actually denied that she had ever tried to hurt herself, at least hurt herself intentionally in an attempt at suicide. The patient denied that. History of multiple psychiatric med trials, but she reports doing the best on lithium. And she was feeling significantly depressed with pretty profound mood swings, but no suicidal ideations. Her mental status exam, meaning the way she presented at the time of the first appointment, was relatively benign. So she has unstable housing. So she lives with father of the baby who is abusive. And it's important for you to gather that history. As we talked about in the first lecture, gathering social history with these patients is very important. And the way that we elicit this type of a history is we ask them, where are they staying, right? Are you staying with anyone? Or are you currently in a relationship? And if they say, yes, I'm in a relationship, then you say, with who? Always ask the person's name. That makes it a little bit more personable. And if they say, yes, I have a boyfriend. Oh, so what is your boyfriend's name? Oh, Steve. And then I ask this. I say, so how does Steve treat you? Okay. Or how is your relationship with Steve? How is that going? This will give you, at least in some cases, a good deal of information. And if you're suspecting that there is an abusive relationship, you can just directly ask them, are you being mistreated by anyone? Or if they tell you their boyfriend, you can say, is Steve mistreating you in any way? It's important to be careful what words you're using. Using a word like mistreat is better than using the word abuse. Patients may be less likely to respond to you or to give you an accurate portrayal of what's happening if you're using words like abuse. So it's important to use, words that are a little less, words that are a little lighter and maybe carry less weight, like asking them if they're being mistreated. Okay, she was previously living in hotels. She has 2 children who are living with their parents. She has significant legal charges and possible prison time due to drug-related offenses. And now also getting a legal history is very important. When you're gathering the social history at the time of the first visit, we usually ask the patient that directly. Are you currently facing any legal charges, any difficulty with the law? And I'll usually say, try and make it, lighthearted and funny. I'll say, are there any men or women in blue that are currently looking for you? Really no reliable support, possibly her grandmother. But she really didn't have anyone in her life that she could really rely on. So you can pause the presentation right now, and you can think about what you would do. What you would do to help Becky. Okay, so we had recommended methadone maintenance to her based on her history. Again, you have somebody that was prescribed buprenorphine who is in a residential treatment program. She's on the buprenorphine, but within days of being discharged, she's back to using again. This is very concerning. And when we have a patient that's pregnant, we don't have a lot of time. So we're very aggressive with regard to our treatment recommendations. And so when we saw that she was still using, she's pregnant, we're like, methadone. And, we need to ensure that you're sober. We need to ensure that you have a healthy pregnancy. And this is what we're going to recommend for you. We also recommended inpatient treatment, but that was also declined. We did provide her lithium, 300 milligrams 2 times daily, because she reported significant therapeutic efficacy with this. So given her, she did not want to go on methadone. She did not want to go into inpatient. She said she wanted to stay on the Suboxone. We agreed to provide it to her. We felt that this was a harm reduction approach. We certainly had concerns that this wasn't working, but you know something, if this is going to stop her from using heroin, then, or if at least it's going to stop her from using a lot of heroin, then we're willing to take that chance. So visit number 3. So she reported continued use of methamphetamine. She said she used 3 times since the last visit. So obviously that was concern to us. She also reported using unprescribed Xanax and Seroquel, but denied any opioid use, and she was happy with the prescribed buprenorphine. She says that she was considering adoption, and we had her meet with a social worker to talk about that in more detail. She was provided a 1-week supply of buprenorphine, and we got a urine drug screen, and the results were uploaded the next day. So what do we see on the UDS? We saw buprenorphine, methamphetamine, amphetamine, fentanyl, norfentanyl, and tramadol. So this is what we had on the UDS. Any suggestions, or what would you guys do at this point? So obviously, multiple concerns come about. We attempted to contact the patient to discuss the UDS results. There was no answer. And again, I think you see the common theme here, if you've been listening to my prior lectures, is that when you have a drug screening result that shows something like this, you need to call the patient. That's the first thing you need to do. You need to call them. You need to document in their record that you call them. You need to have a quick conversation with them. And again, just to review what we had talked about in the past presentations, you don't make assumptions, you don't make accusations, you simply present the results to them and you ask for an explanation, right? So the conversation would go something like this. Hi, Becky, how are you? Dr. Junie from Michigan Medicine, just wanted to review your drug screen results. I want to go over these with you. It's somewhat concerning to me. It shows that you have buprenorphine in it, which is what we had expected, but it's showing methamphetamine, amphetamine, fentanyl, and tramadol. So can you help me understand why those are in your urine, Becky, or some variation thereof, okay? And then you let her explain, and then you have a conversation. But as we talked about here, there was no answer, and she no-showed to the next follow-up visit. So now we're worried. No answer, she didn't show up. We made multiple attempts to call her. There was no answer. There was no option to leave a voicemail. The other thing that was concerning is that we gave her a 1-week supply and she didn't call for a Suboxone refill. So now we're getting really worried, because at least my patients that no-show, they will ask for another refill on the medicine, but she did not. So now we're getting a little anxious. We wait another week. And again, we call her. There was no answer. We finally decided it was best to call next of kin at this point. So now we're kind of escalating things. We had a contact number for her grandmother, and we were happy when she answered, but she said she hadn't heard from her in 2 weeks at her last appointment date. So what do we do? So the social worker suggested doing a wellness check, was to call law enforcement to have somebody do a wellness check on this patient. Do you guys agree with that, or would you have done something different? She actually resurfaced. We elected not to do the wellness check, and the reason why is that we didn't. We basically have somebody that's a polysubstance user that just wasn't coming into her visits. We didn't really have. We had no evidence that she had attempted to inflict self-harm. We had no evidence to suspect that she was in danger. And the biggest thing was that her grandmother was not concerned. That's really what kind of prompted us not to go that route. Because when we talked to her grandmother, she's like, this is Becky. She kind of vanishes for 2 weeks. This is just the way she is. So we ultimately elected not to do the wellness check. So she came in. So she finally resurfaced. She came to the clinic after a 5-week absence, and boy, were we happy to see her. At this point, she was now at 37 weeks. She said that she was in Saginaw due to the ailing health of the mother of the father of the baby. She had been out of buprenorphine for quite some time and had been using heroin. She also reported intermittent methamphetamine use. and her urine drug screen was positive for morphine and methamphetamine. So what would you do? So again, I don't want you guys just to go through this presentation. I actually want you to pause it, and I want you to spend a few minutes actually thinking about what you would do and how you would manage this case. The benefits of doing this live is that we would have the participants engage in a discussion, and we would engage in a dialogue, and that kind of helps. And it helps hearing from others and hearing different perspectives. So we had a group discussion about this. The case is obviously escalating. Things are not getting better. This is just getting worse. So we had suggested an admission for an induction of labor for baby safety because the patient's status was clinically deteriorating. So we're talking about actually bringing her in and admitting her, and really with the OBs that I've worked with, they said, we need to get the baby out. And I've heard that phrase many times. And that's really what it is that you want to do. You want to deliver this kid. You want to deliver this kid ASAP, because this is a deteriorating situation. So we basically were quite aggressive in letting her know is that this is what we want to do. We want to kind of end this pregnancy for you because you're not doing well. Let's get this baby out. The OBs feel that it's healthy to do that it's fine, but she declined. We also offered her an admission to an addiction treatment facility with recommended that she go on methadone. She declined that. We provided her a 7-day supply of buprenorphine to help mitigate risk of overdose and death. This was a difficult decision. This is when I told you at the beginning of the presentation is that we're doing things here that are not evidence-based. We're doing it on clinical intuition. And this is it. Right now, many people will look at this and say, you have a patient that's using she's using multiple substances. She's using heroin, she's using methamphetamine, she's falling out of treatment. She goes missing for 5 days, or she goes missing for 5 weeks, and you're going to put her back on Suboxone. The answer is yes. And the reason why we did that was because it was the only thing that I could do to at least attempt to help mitigate a bad outcome. So this was a very difficult decision. It was discussed with all of the clinicians involved. And when we did this, we did in a very articulate way, this was placed in her medical record of why we're doing this. And really what we wrote was that we're trying to prevent death of her and her baby, because this is the only thing that we can do, because everything else has been failing, and she's not agreeing to engage in any of the treatment recommendations. And we're not just going to turn our back and say, well, you don't want anything, so goodbye. We at least wanted to try something, and she was stating that this would help. Now, is there a possibility of diversion? She's going to take what I give her and sell it, of course, but you have to work with your own conscience. You have to make that decision. Now, am I saying that this was the right thing to do? Am I saying that if you're confronted with a similar situation, this is what you should do? No. I'm telling you is that you need to use your clinical intuition. You need to look at the case. You need to gain as much experience as you can in working in this field. And you're the one that has to determine what is best for this person. You're the one that's going to have to live with the decision, and you're the one that's going to have to document it within your medical record and potentially defend that and potentially defend the decision that you make. But in this case here, I basically stand by what we had done. I felt it was the best thing to do. So we don't know what happened to her. At the time we did this, at the time I did the slide set, she was still pregnant. I know that she did deliver. I know that her baby was healthy, but she stopped coming. After she delivered, we never saw her again. But the good news is that the baby delivered. The baby delivered, and the baby was healthy. I don't know what happened to the baby. I know that she had talked to the social worker about adoption, but I just hope she's doing well. And I hope that if she's not, I hope she's engaging in care somewhere. So takeaway points from this case. Sometimes we need to engage in a harm reduction approach. Sometimes we need to kind of live in the gray area and do things that are off of the beaten path. We want to create an environment where the patient is willing to come back to you regardless of the circumstances. And that's exactly what she did. Despite everything that she had been through, she still came back to our clinic because I'm hoping that part of the reason was because we created an environment for her where she could talk to us. If you create an adversarial setting where the patient is going to feel shamed and judged, they're not going to come back. And especially in a case like this, then you risk overdose and death. If cases are too complex, you want to reach out and ask for help. So that's the other thing. There's the Michigan Opioid Collaborative, and there's other organizations throughout the state that can help clinicians through teleconsultation services in managing some of these more complex cases. And again, I have here in bold, you want to treat the patient, don't treat the urine drug screen. And you always want to document your reasoning, especially in cases of high risk prescribing. Acknowledge that this is a high risk, situation, but you're engaging in this treatment to prevent a potential overdose and death, and that you will appropriately monitor the patient. So you can't just, do this type of high risk prescribing and not put anything in writing. You have to express why you're doing it. And again, as I talked about in the last slide, it was basically is that I'm trying to prevent the death of this mom and her baby. And right now, given the situation and what she's willing to engage in, this is the only tool that I have. So that brings us to the end of the presentation. We can go ahead and talk about the action period assignment for next time. So as we discussed, we discussed basically 2 high-risk cases with two different approaches. During the first case, or rather, one case involved prescribing buprenorphine in a high-risk situation, and the other involved not prescribing buprenorphine in similar circumstances. So I purposely chose these cases because our treatment approach is very different. So the first one was several years ago when we were very conservative and very careful about prescribing Suboxone. The second one was the opposite, is that we were more liberal in providing buprenorphine to the patient. So we kind of see 2 opposite ends of the treatment spectrum there. So prior to this presentation, what was your opinion on providing buprenorphine in the context of active substance use? And did these cases change your viewpoint? Why or why not? I'm not saying these cases should have, I'm just asking you if it did. Okay, the second point here is that we have some clinics have very stern controlled substance agreements which stipulate that any drug use outside of what is prescribed may result in dismissal from the clinic. While we have discussed the clear advantages of this approach, can you think of any advantages? Pardon me, let me read that again. Sorry, it's the end of the presentation, my tongue's tied. While we have discussed the clear disadvantages, so the disadvantages of very stern controlled substance agreements, can you think of any advantage to taking this stance? Meaning, can you describe any advantage of using a very strict controlled substance agreement with your patients? So that brings us to the end. I want to thank you for participating in this presentation. I enjoyed providing it, and I hope that you gained some clinical pros from it. I do have my email address there at the end if any of you want to drop me an email if you have any further questions. So again, thank you for taking the time to listen, and I look forward to providing another lecture to you again in the near future.